intervene, sir? No
No,
problem.
sir. Please, sir. It's already late, so I
I know.
thought I.
No, just I'll finish it off in 5 minutes. Okay,
Yes,
sir.
sir.
I'll finish.
Please.
Yeah. Okay, and ma'am, you just keep. I'll just for the sake of time restriction, I'm just going to 10-year-old child presented with complaint of fever, fatigue, generalized lymphadenopathy, hepatosplenomegaly, membrane over tonsils, peripheral smear. Okay, here I'll let you tell everything on my own. Ma, you just don't know. No, just go to the yes. This is atypical lymphocytes. This is the diagnosis. All of you know it is nothing but Epstein-Barr virus. One of the forms of the disease, one of the diseases that is caused by Epstein-Barr virus is infectious mononucleosis. You know that. Infectious mononucleosis, triad, I told you before, pharyngitis, lymphadenopathy, myalgia, and fever. These are the three very, very important. So look for oral cavity. You may see the exudative lymphadenopathy, which is a close mimic for streptococcal pharyngitis. So keep that in mind as you had a discussion ampicillin rash. Just I want to put one word about ampicillin rash. That is because of this transient hypersensitivity to the ampicillin or amoxicillin. It doesn't mean that the child should not be put on amoxicillin in the rest of the life. Because this EBV transiently increases the sensitivity of ampicillin or amoxicillin to these patients. Once this infection are over, probably the child can take amoxicillin. But at that point of time, you always keep in mind, if the child, if inadvertently if the child is put on amoxicillin and develop rash, nothing much to worry. It will settle on its own. Please, what is the next question, ma? Next question. Yes. What is the one question? One more question is there. What is the diagnostic? Okay, there are plenty of the serology. Just the diagnostic serology is IgM against viral capsular antigen. Okay, IgM VCA is the diagnostic. There are certain differences, but I don't want to discuss all those things. For PG level, if the child presents with as I said, the triad of pharyngitis, cervical enlargement, cervical endopathy, fever, with the positivity of IgM, VCA antibody, then the probably diagnosis of EBA is made. Treatment, nothing much to be done. So steroid is restricted for certain complications. You don't worry about that. But it will be there for up to 3 months. Yes, next one. Keep watching the child for complications. That splenic rupture, as you read in the book, is not so commonly seen. Okay, as far as EBV is concerned. Second question, 5-year-old presented with a daily fever, quotidian type, it is proceeding 2 weeks, evanescent rash, disappear. Okay, here, yeah, this question was framed only to enlighten you about, always think of non-infectious causes as well, because we are discussing about MISC. Okay, all those, that is directly, it is infection, it is only inflammation. So always keep this non-infectious causes in your mind. This is a case of systemic onset juvenile idiopathic arthritis. There is no findings of arthritis abdomen, never think, because this monoarticular and polyarticular arthritis will present as a joint pain, whereas SOGIA, that is systemic onset juvenile idiopathic arthritis, present only as a fever with rash, hepatosplenomegaly, and polycirrhosis. Just keep that as a mind. And the clue is always they'll be having neutrophilic leukocytosis, thrombocytosis, and elevated markers like CRP, ferritin, ESR, all those things. That is the diagnosis. So that repeatedly I'm telling you, nowadays we are seeing more number of rheumatological disorders. Keep this as open, and we think of non-infective causes whenever you come across prolonged fever. Please go to the next one. Okay, this is nothing but the BCG mark is there, lymphadenopathy is there. It is BCG adenitis. There are two scenarios we will come across. Is it a fluctuant or non-fluctuant? There will only two things. So if it is non-fluctuant, don't do anything. Just leave it as such. It will take even months together to resolve. If it is fluctuant, put a needle and aspirate it. Okay. If these are the two treatment. Never send the aspirated specimen for Zil-Nielsen or Gene Expert. Invariably, it will be positive. No need for ATT. The message is non-fluctuant BC adenitis, no treatment. Wait and watch. Fluctuant, aspirate. No role of antituberculous drug. Next one. Okay. This is 8-year-old admitted with fever, conjunctival suffusion, lymphadenopathy, following a scene other. This is only differential diagnosis. Probably you can say scarlet fever. Only scarlet fever, only one thing, it is a streptococcal infection. But since it is in the acute, it appears in the first week, you may not get ASO positivity in this child. That is the one clue, fast lines, all those things. All the differential diagnosis of Kawasaki, everything you can think of, all those things. Next one. So the diagnosis is scarlet fever. Yes, ma. Next one. Here, yeah, the mostly it is known. Can you appreciate the nematoceles, or can you appreciate nematoceles? This is nothing but a staphylococcal pneumonia. Drug of choice is there are two classifications: methicillin sensitive or methicillin resistant. Yes, please. Yes, methicillin sensitive means you can use cloxacillin. Methicillin resistant means you can go for other drugs like linezolid or vancomycin. Yes, ma. Next, treatment is, and it will take longer time to resolve. Treatment is for 4 to 6 weeks. Yes. This is a 7-year admitted with fever, rash, abdominal pain, NS1 antigen. This is one of the complications. Like MASC, this is a complication. This is a bit higher level for UG, but there is no restriction in knowing the subject. There is no restriction. UG should not know something like that. It is not there. So a 7-year child who presented with the dengue but deteriorated, we expect the child to improve usually after 5 or 6 days if the child is not going for critical phase. That is the commonest thing. If the child enters into the critical phase, the child will be sick for the next 2 to 3 days. And then the child will start showing recovery. But if the child continues to be sick, even beyond the expected time of critical period, if the persistent thrombocytopenia, if the child continues to have high-grade fever, then one of the complications you have to think of is HLH, hemophagocytic lymphohistiocytosis. So for that, the investigation is you look for corroborative markers like serum ferritin and triglycerides, elevated serum ferritin and elevated triglycerides. The bone marrow will show the engulfed this one. Macrophages are engulfed. Then then the diagnosis is HLH. That is, treatment is a bit different. Steroids and even other immunosuppressants also considered. Just be for UG level, you be familiar with this complication of HLH. Is one of the complications we observed in dengue fever or HLH or Epstein-Barr. These two viral infections.
Sorry for interrupting. Sorry.
Last one slide, sir. That's all. Yes,
sir.
One
minute.
Yes,
sir. Regarding this one, I think that students should understand that maybe dengue they may start to recover. Again, that going for fever. That's very important thing.
Yes, sir. That's why. The reappearance of fever, progressive sickness, persistent of fever, beyond the fall of thrombocytopenia, beyond the expected period of recovery, all those things, please think of HLH. Anything you want to add, sir? Please.
Yeah, that's why. Okay.
Yeah.
Sir, sir, you want to add anything?
No, sir.
I know, sir. It is very, very sharp because of so many issues. I'll finish off in another 1 minute, sir. Yes, pa. Next slide. Yes, this is nothing. All of you, please listen. This is rashes which involving palms and soles and over the buttocks, and this is nothing but Coxsackie A viral infection causes HFMD, the hand, foot, mouth disease. It is no need for any treatment. It recovers on its own. Be familiar. Very rarely, very few rashes only involves palms and soles, like a ricket cell infection. This is one infection we call it as a CARS. I just heard that mnemonic. C for Coxsackie A, which causes HFMD. Then R for ricket cell infection. S for syphilis secondary, which is not so commonly seen nowadays. And one more S is always think of staphylococcal toxic shock syndrome. All those syndromes that can present rashes with palms and soles. And this is you read about always. You see whether always this whenever you see rashes, palms and soles involved means we can narrow down so many things. This is hand, foot, mouth disease. No need for any treatment. Okay. And most of the time, once the child becomes afebrile, defervescent phase, once the child becomes afebrile, the rashes multiplies and it becomes more prominent also. Nothing much to worry. You have to ensure, and you can see even oral findings also over the palate, everywhere. Okay, my next slide. Okay. Hello. This is. Hello. This is a typical rash. Is typically seen. This rash is a dengue rash. Especially there are two types of dengue rash you will be noticing. During acute infection, we will be seeing what is called as macular erythematous rash. When you just touch the baby and see, you can see the dermographics. You can see your hand impression. That is a macular erythematous lesion during the acute phase of illness. During second day, especially third or second day after 48 hours, you will be getting that type of rash. But once the child in the recovery phase, you will be getting this type of rash. This is a little bit pruritic rash. This type of rash. This nothing much to be done. You can very small amount of aspirin antihistamine can be given for this rash. This is the second phase of dengue fever. Okay. This is called white islands in the sea of red. Because please Everywhere it is red with white specks alone you can see. This is in the recovery phase of dengue. Okay, then last slide. This is, everybody, it is Eshka. You please look for only in the covered area, never in the exposed area it is seen. One important point, it is painless. For UG level, you please keep it as a painless. So mother will not say. Okay, you have to look for that. Next slide, last slide. Okay, this is nothing but a banana-shaped gametocytes. It indicates Plasmodium falciparum. You know that it is the severest form of malaria. The treatment of choice for Plasmodium falciparum infection is not chloroquine. It is artemisinin combination therapy, ACT. Okay, sir. That's all. So sorry, sir. Sorry for the delay and so many interruptions we had during this thing. We want to really sorry. Okay, sir.
Dr. Sir, you want any comments, sir?
No, sir. Thank you very much, sir, for giving us this opportunity. I hope all the students have learned a lot today because of the extensive lectures that sir has also given, so many slides also. So thank you all, sir. Thank you very much for inviting us to this program, sir. On behalf of us, we thank the IAP wholeheartedly.
Yeah, today I think both legends, I think you are there. That's a big problem. Yeah, you can't, enough you can't talk about this big problem. Okay, no problem. So on behalf of IAP TNSC, I thank Dr. Ramanathan, Professor of Pediatrics from Annamalai Medical College. Another one is Dr. Suresh Kumar from the Viluppuram Medical College. He is Associate Professor. They are both are so extensive knowledge they are having. And students also presented nicely, they presented. And then we have problems like internet. No, that's we can't do anything. Okay, so overall the good presentation. I thank one and all for the opportunity. I thank all the students who has attended this program, and I thank Dr. Thirumurugan who has